Who I am is I'm Mark McWilliams. I'm an osteopath in Cardiff. I was a migraine sufferer before, and migraines were a very part of my life from the age of 7 to the age of 21. Luckily, I don't suffer with them now. But that's where my interest in headaches really began, from being a sufferer of it. And I used to get the auras, and this is a picture of me, what I felt like when I had a headache, really. I had blurred vision, dots in front of the eyes, had to be in the darkened room, the typical features of it. Somehow, I managed to lose my headaches after manual therapy. I can't remember, it was an osteopath I saw. I was 21 and I can't remember where it was. But there's someone in Manchester at the time, and they helped me significantly with my headaches. And after that, I had to train as an osteopath, and I went on from my training to learn more about headaches in a Master's in Pain Management at Cardiff University, where, as Helena said, my dissertation on migraines and tension-type headaches won the Welsh Pain Society Award, which is always funny when you put a certificate saying you're the Welsh Pain winner in your because everyone's going, hey, what are you into? So, anyway, but I don't want you to remember anything about me today. I want you to remember about this guy. Does anyone know who he is?
Snoop.
Hey, he is Snoop Dogg. We don't want to know him as Mr. Dog. We want to know, just remember his first name. Snoop. Okay? That's all you have to remember. You'll know why later. But this is the guy that you have to remember when you're talking about headaches. So remember him. So what are our learning objectives today? Well, we want to know how to approach the headache patient and screen for those red flags, really. That's the key element of primary care practice, is what we're doing is safe and appropriate to do so. And how to get an accurate diagnosis and determine if the headache is primary or secondary. Now I'm going to use a case example which, that it has been relevant, it's been authorised by the patient to be used anonymously for this case. So I'm going to use a patient outline to see how my process, using diagnostic algorithm, a very simple one that I use, and the red flag screening, how it'll demonstrate that for you. So that's what I aim to show you today. So, the starting point, evidence-based, is the key thing. And the evidence-based is the night. I want to hammer this home, pardon the pun in the slide, but it is the key thing, is you've got to make, if you know these three things with headache, when you start, this is the key. Headache is a symptom of many disorder. It is not just one thing. Go into your practice with anyone comes in with a headache. There's 158 types of headache that I know of. Now, I think there's probably more. And if you look at the IHS guidelines, which we're going to show a little bit later, I'm not going to go through all 158 headaches. It's the key is the stepped approach to diagnosis. If you don't step your diagnosis, you can get in all sorts of trouble. But if you take a simple step pattern with headaches, that 158 can be filtered down quite easily. And consider the possibility is the key that there's more than one headache comes at a time. I mean, simple things is, you know, you can easily have a migraine and a hangover together. There's two headaches going on there. So you can really make sure that you know that it may not be just one headache you're dealing with. There is a possibility of two. Now, if you remember those three things with headaches, that's nice guidelines in their assessment. The latest one was 2012, which is what that is. They have done updates on certain types of primary headaches, migraine, tension type headache. I think possibly since 2012, but their main guidance for primary care are these three things. Is a good way to start. And the diagnosis, what we base it on? Well, there's the IHS classification. It's the structural approach to take. If you're not aware of it, if you've not seen it, you can easily access it. You can easily access it through the headache websites, but you can also access it purely online with a Google search. The IHS classification, and the new one is the ICHD3 beta. That's the most relevant and up-to-date one. And it's the structure of the classification, which is the approach to take. Make sure you've got that structure. And the basic structure is this. And it's not an easy slide to see, but it's the devils of the headaches. And there's the main ones is you've got primary and secondary. And your primary ones being your migraine, your tension type headaches, your cluster headaches and other TACs, other primary headaches, it can be chronic daily headaches, those sorts of things, and then you've got your secondary headaches. Well, the first one to get rid of all those is the secondary headache. That's the devil you want to get rid of first. You can get rid of the secondary, then you can then deal with the primaries. And it's what the NICE guidelines say. From all the expert opinion that the consensus is that you've got to exclude secondary causes of headaches before you start there. So don't jump into saying it's a migraine, it's a tension type headache, it's a cluster headache, until you've really looked at the secondary causes as well. That's the key. So where do we start? This is my simple algorithm, and we'll start with the where we all start in practice, a detailed history and examination. That's where we have to start. And in this case, I'm going to show you through the case of a patient of mine, as I said. In the detailed history that I've had was a 49-year-old man. He presented with headache amongst other symptoms. He had cervical pain and thoracic pain as well. He had no previous history of headache. And the only other significant thing in his medical history was hypothyroidism, which he was taking thyroxine for, which had been maintained on it for years and was not a problem at all. His headache description had started 2 weeks prior to him coming to my clinic for the first time. It was an intense shooting pain into the occiput, associated with vomiting. He had 3 days of vomiting, which had cleared by the time he had seen me, but he was still feeling nauseous. He was getting lightheadedness, photophobia, and neck spasms. He was acute there. He'd been to see his GP on the Monday. This started on, I think, a Friday, so he had 3 days over the weekend where he was being violently sick. He couldn't really, he said he couldn't leave his toilet bowl. He was that bad for 3 days. And his GP diagnosed it as a clamped muscle and sent him away with some wonderful analgesics and said that would do. That's what he had. But he arrived at my clinic a few days later, literally just a few days later, and he had eased into a bilateral occipital temporal headache. He had pain coming over both sides of his head. He had a lot of neck tension, which he was complaining about, which is why he'd come to see an osteopath. I think he'd been recommended me, so he thought, oh, I'll go and see what he can say. Because he was still getting headaches with the analgesia the GP was giving him. He had light sensitivity. He couldn't do any work. He couldn't read. He couldn't do any of his work at all, and he couldn't even sleep. But the funny thing is, he said he wasn't missing sleep. He said he didn't mind not sleeping. He felt in a sort of cathartic state all the time. Family history. He had a mother with migraine, a father with a thyroid dysfunction, which maybe a genetic factor why he has hypothyroidism. And his social history, well, he was a TV producer. He had a lot of stress at work. He deadlines, scripts, editing, pressures with the production of films for TV. He did exercise. He enjoyed his exercise. He was generally fit and active. Did 2 to 3 work sessions at the gym, generally in the morning before he started his day's work, which would often be 12-hour days in the TV production industry. And he was basically married to his work. He was not married and no children there. Aggravating, well, it was aggravated as we go through our case history. We can see that it was aggravated by lying down, sitting, reading. As I said, he couldn't do any of his work, his scripts, and he hated light. He was very much not liking light. He was, bizarrely, eye gel mask was really helping him. He loved his eye gel mask. He said that's the best thing that he'd had over the last few days. And the ibuprofen, although which had been prescribed by the GP, he was helping, but not as much as he wanted it to be as well. So already in the detailed examination and the detailed history, we're trying to form a picture of what is causing it. But we've got to make sure we look at the systems as well in his body as well. Which we do as osteopaths, so we're quite good, and it's making sure that we're looking at the whole picture. And that's what we mean by detailed history. Don't just do the musculoskeletal, make sure you review the whole system. His appetite was normal, and his weight was as normal. He wasn't finding that a problem. He was describing stated no cardiac, respiratory or GI signs at all. Non-smoker, moderate drinker. He said nothing unusual. He hadn't been out before his headache on a Friday night. It wasn't like it was the end of a strict production meeting where they can go out and drink heavily, but he said no, he hadn't been that week beforehand as well, so he said he moderately drinks. And he said his blood pressure was fine with the GP. Now this is the interesting thing, if anyone says it's fine, what do they mean by fine? So I took it, because I thought, well actually, we've got to take your blood pressure, what do you mean by fine? You know, so, and I don't think that's fine, 154 over 98. I don't know if anyone else has found that that's fine blood pressure. I think that's a high blood pressure, but that's what he'd been told by his GP. Now whether he had white coat anxiety, all those things, but you'd expect it with the GP as well, and he was in a more acute state. And he had we did a cranial exam, and we looked light response as well. With all these symptoms of this acute headache, we wanted to find out what was happening in the neurological system. There's no notable significant neurological findings that I found on my brief examination. So where was I at today? I had to go to this next stage of my diagnostic algorithm. Headache alarm. Well, there look like there's some alarms there in his headaches, would you agree? Absolutely. It's not just a straightforward everyday headache that he was getting. And the red flags are present. And the key is, if you suspect red flags, obviously, secondary, you've got to exclude the secondary first of all. So without even going down to looking for a primary headache, really look for your secondary headaches. And the key, as I said, if you remembered his name, it's Snoop. And this is the way to do it. This is the algorithm to find out headache red flags as well. And it's the one which is sort of tried and tested, and it covers it all. So, I'll just go through it because I think it's one of the most important things you should know. It's the systemic symptoms, fever, weight loss, what we would normally look for in terms of anyone who's generally very unwell. Or secondary risk factors. Obviously, have they got any other disease, which may be secondary and causing their headaches as well, which may be that it's actually to do with that rather than their headaches. So look for systemic first, that's the S of the SNP. The N, the neurological symptoms or abnormal signs. From the main ones are the obvious ones. They're confused, impaired alertness, drowsy in your consulting room, they've lost consciousness at any point, particularly even with your trauma head injuries for rugby. I mean, we get a lot in Wales rugby and those sorts of sporting injuries. If it's a trauma impact, loss of consciousness, get that as your make sure that you've got that as your neurological red flag as well. Because it's really important. So that's your N side of it. Onset. Sudden, abrupt, or split second. If someone's had a sudden headache, never had it before, split second, cracking headache, thunderclap, suicidal, these are the words you hear in clinic when someone's had that, and you just know it smells red flag, basically. So if someone's had a really acute onset, and if they're older, generally they're saying greater than 50 was the ballpark. I think anyone over 40, I don't know if Helena and everyone agrees, I would be, the red flag would certainly be going amber to red between, over 40. So I think don't take 50 as the figure really is the key one of that. But it's a new onset or a new type of headache that they've got, and that's where the P comes in, of the SNP, the previous headache history. We said before that the more than one headache can exist at any one time. So you said, I've always had migraines or something like that. And that's, you think, it's just a migraine attack. No. If it's if the headache has changed, if it's in frequency, severity, or clinical features, or it's the first headache of something different, then you have to have that SNP. Any questions on SNP? Because I think that's one of the most fundamental important things on headaches is getting your red flags sorted, because you can do that and refer straight away. So, obviously with this guy, we didn't have the S or the N so much, but we had the, I put it this way rather than POO for one reason. So it's the onset, it was sudden, he had that sudden onset of headache, that 3 days on the toilet headache where he just came on out of nowhere. Older in age, he was 49. Well, there's a question, around 50, so we're looking at that. We know that he's of that age where middle-age headache. And previous headache history, he hadn't had any previous headaches of anything like the ilk that he had this one. So it was a red flag to me. I referred him off, smugly thinking, I know what's causing it, it's the sentinel bleed. You can get these sentinel bleeds which create subarachnoid hemorrhages. They basically present a few weeks in advance of a subarachnoid hemorrhage. They're not as acute and they often go away. You get a sudden unpack there. Look them up. Look up the sentinel bleeds. They're rare, but they do happen. And then they go away, and then what happens is they get dismissed a lot in A&E departments as well. They go back 2 days later, 2 weeks later, they're dead because they've had a subarachnoid hemorrhage. And it is one which is always not so. But I thought, I can't rule out that possibly he's had that because which has created which may be that. So I thought, sent him off to A&E immediately from the clinic room with a letter of referral and things like that. And then I didn't hear from him. I rang him a few days later, didn't hear from him, thought, God, I hope you're all right as well. Well, a week later, he presented back at my clinic room. He said, I had all my scans, I had everything's fine. I've still got a headache. Can you help me? Now that we've ruled out the sinister aspects of it. Well, obviously, I felt, well, we did the right thing. It was the right thing, even though it wasn't a sentinel bleed in this case. It was right to refer him. That was the key on headache management. So we're looking at what it could be next. So we're on to the third tier of our diagnostic algorithm. We're up to this consider a primary headache. Now we can start considering it, but we still, I think the key thing is we still want to reconsider a secondary headache. Never sort of stop considering that until you rule them out. So remember, it's secondary until proven otherwise. So we need to go back and examine him again and see exactly what's going on now, knowing now that the red flags, the snoop, has been taken care of. But we also want to make sure that they haven't missed anything. We can't say that any medical diagnosis is 100% accurate. But before you can know what is the primary, before you can go into sort of ruling out primary and secondary, you have to know your criteria for primary. And if you don't know your criteria for primary, then you're shooting in the dark. So really know these. I think the three, and know there's obviously more than just the three main ones, but I'm just going to go through the main ones. With migraine, I'm only going to talk generally. I'm going to let Helena talk all about the different types of it with aura, all those other aspects of migraine. But I want to just give you the basics of what you to look for in clinic. And this is the thing, if someone comes in, a lot of people say they have migraine and they don't have migraine. If they don't have these classifications, this is the key that you want to look for migraine. As there are atypical migraines though, so do remember that. They don't always present exactly as this. But this is the guidelines. You've got to have 5 attacks fulfilling D to D, really, and B is 4 to 72 hours. For our patient, 3 days, and acute headache, 72 hours, you could say that could be in that one. 4 to 72 hours is the key sort of looking at that as a general rule. And you've got to have 2 of these other things. Unilateral, so it's got to be one side. Our patient had a bilateral headache, so it doesn't look like it's going to be migraine for that. Pulsating. On his exam, I haven't put it on the slide, but yes, I asked the quality of his headache, and he said it's sharp, intense, stabbing-like rather than pulsating. But yeah, it tends to throb, migraine. It tends to be that throbby pain. It's moderate to severe pain. You can get very high, intense migraine pain, and some people get minor pain just behind their orbital. And it can be increased with physical activity. That's an important part as well. But there are other types of primary headaches which aren't increased with physical activity, or through their definition aren't. So ask about physical activity. This guy went to the gym. Did it get worse when he went to the gym? Well, he wasn't going at the time that I was going, but he didn't like, his worst was actually when he was stationary, sitting. He talked about being there, not when he was walking. But if they feel that movement or anything like that increases it, then that can be part of those two. And then D, of course, the other signs of migraine, the nausea, the vomiting, the photophobia. They don't have to have it all, they just have to have one. So if they're non-nauseous, but they've got photophobia, then that could be a migraine, if they've got fulfilling the other characteristics as well. So It's about that B to D together. So if you know B, C, D on that one, then you're going to be fine. And 5 attacks is what they say as well. So it's hard to diagnose someone's primary migraine after 1 attack.
Can I just ask, the 5 attacks, does that have to be in a set time period?
Month. That's I would say that within 5 attacks over. I look for it how many they've had over sort of if they're having a month. If they're having monthly migraine 5 times, then that's 5 attacks. So if you have it once a month for 5 months, then that can be it as well.
Thank you.
But I think you probably, Helena, you've heard more than that. Did you?
No, I think it took me a while to work out why that was so important, but because it gives time for other conditions to unravel.
Yeah.
Obviously, I'm not going to steal your thunder here.
No.
But do you know that nice pound mnemonic for that sort of pulsating 1 day, which is not strictly true, it's 4 to 7 to 2 hours, but they're typically 1 day, better by sleep, so pulsating 1 day, unilateral, nausea, and debilitating. But they're just, that's not classification, it's just a nice mnemonic to help you remember.
Yeah.
You can just drop these on your case histories, can't you? Just tick
Yes,
boxes.
exactly. Yeah, just look at that. So the other primary headache that you've got to know the typical features for. As I say, we're looking for is it primary or is it secondary? So we're looking at the primary things. And again, these are important to know. What the tension type headache? They're sometimes they can remember more than one headache can come together. You can get migraine and tension type headache together. They're not mutually exclusive. So these ones tend to last 30 minutes to 7 days. That's the key. So they're slightly different than that. Their main characteristics, which are different from migraine, is they're bilateral. They don't tend to have the pulsating. They're more pressing or tightening quality. They tend to be milder or more moderate than the severe pain that you get with migraine. And they're not generally aggravated with physical activity. That's the general rule on the classification of tension type headache. Episodes of pain don't generally have the nausea or the vomiting, but you can get photophobia or the phonophobia. You can get one of those as well. So if they're getting photophobia and they're getting their bilateral headache, we're probably looking more towards tension type headache as a first port of call rather than migraine. So do make sure that you're covering all bases. And the NICE guidelines also say that headaches that is not caused by other conditions, such as obviously fever, paroxysmal illness, anything like that, or medication overuse as well. And we're going to come back to, I've made that highlighted that because it's something I want to come back to you as a common secondary headache or a debatable common secondary headache, more than the other that you've experienced.
That causes them?
Yeah.
You mean not inside the brain, sort of,
Yeah. Any
chemical changes causing vasomotor changes, pressing on the trigeminal nerve?
Yeah. So again, many things can cause it. This is the thing. Don't miss them. Is the key thing. I don't treat them. Corinna, do you treat them or do you?
I'm experimenting at the moment.
Yeah.
But not for money.
I don't feel practiced enough to treat them, and I don't feel that I'm going to actually make a difference to the patient who's got them. If I did think I was going to make a difference, I would treat them. That's up to your individual evidence on treatment, and if you want to do it. I personally refer them to a medical professional, generally a neurologist, for those as well. But the key is, they can have this suicide headache, this nasal thing. And the great thing is get the patient to do, this is the only thing where I actually promote selfies. I've got 2 teenage daughters and I hate the idea of selfies. But headache selfies are brilliant for cluster headache patients. Take a picture at the time that you're having a headache. A cluster patient will look a bit like this guy here. He will have a droopy eyelid. He will look absolutely horrendous. But the time that he actually gets to your clinic, he make absolutely fine. So get him to take a headache selfie if you're worried, because that will really tell you a lot about it. So I think it's one of the best diagnoses that I was told by neurologists that in the modern era to do to help diagnose cluster headache.
Okay. Can I interject once more?
Yeah, of course you can.
I think you can treat them, but you have to have a contract with the patient. I think you have to tell them that you probably, it's very unlikely that you can affect the headache if you can, that's fine, but because of what they do, i.e. they headbang, they shake, they always have horrendous neck and shoulder problems. So if you approach it from the other direction, so we can help with that for sure. It might help your headaches, but don't guarantee that. I think you can treat them, just not treat them.
I think as well, this is where something like the duty of candour comes in.
Yeah.
Because there is fast flow oxygen, sumatriptan,
Yeah.
then things
Oh, well,
that
yes,
work.
and awareness.
And so you can't it's your duty to say, find out which is the patient-centred, go to them, and because these things will help your pain, they'll get rid of your pain. And then if you want to try our treatment alongside, then I'm happy to do it. I think that's where duty of candour comes in.
I couldn't agree more.
And also they typically take years to diagnose, to get a diagnosis. So if you are the first person who thinks, ooh, hang on, that might be a cluster headache, it's important to actually get that properly diagnosed medically, and then they're in the medical system with hopefully the doctor knows something about it. Well, that's the other problem. Don't go again. I hope that's good.
Of course.
A month or two ago, I had a quick decision of patients ringing in because there was a Doctor in the House episode. So chiropractic treatment of cluster headaches, and everyone that suffers from any headache, they decided it's a cluster headache. And it's like saying, can I do the same? That was an interest for me.
Yeah. Really, I don't feel that, I've a lot of experience of treating headaches. I wouldn't touch it. It's not my I think it's the oxygen, it's what those need is other interventions first. It's in the triptans, the oxygen, they're going to do much more benefit. And then if they want to come for those secondary symptoms, I think like Karina said, the head, they do get violent, sort of whiplash type symptoms, some of the patients, from the real intensity of the banging the head. As I say, you want to take your head off in these circumstances.
I think it's not one to play with, because it's called a suicide headache for a reason. Because people do end up putting their head on the train tracks. That's the only way to get rid of it. So it is something to take seriously.
Also, that particular episode of Doctor in the House, I think, was the most complained about programme so far at the BBC this year, and the Ouch, the Society for Cluster Headaches, put out a big communal complaint. Several organisations did that it was incredibly irresponsible the way that it was presented.
It was like, that's it, one click, that'll fix all.
What did they present? Sorry, I don't.
They had a patient with, non-typical cluster headaches, and this doctor sort of swanned in, and there was a part manipulation, and he did some dietary stuff not traditionally used for headaches, and of course she felt much better.
She had this gorgeous doctor living with her for a week.
Yeah.
Who didn't feel better.
Absolutely. Okay, moving on back to our case. This is our 40-year-old man. He's still sitting there waiting. What can I do for him? I'm still going through my diagnostic. Hopefully a little bit quicker than this. I'm going through, but I want to take you through this. So we still think we've ruled out the red flag. I think I'm happy that I have ruled out the red flag at this stage. I'm still worried about how you initially got the headache, but I want to treat what pain he has now, I'm happy with the care that he's had, these scans, the CAT scan and everything. It's not found anything significant. He gets an occasional tingling in his left arm now, occasional. He still has the bilateral occipital temporal pain, so he's still got that pain. His intensity is reduced down to about 4 out of 10, so he feels it's far more manageable. It's still mainly daily and pretty much constant. He's got no nausea. He's still got that light sensitivity. He doesn't like reading. He still hasn't read his scripts that he's meant to read, so he's still a bit wanting to get back to that, which is why he's come back to see me. He wants to get back to work and get back into that. He's still got his neck tension, another reason why he came to see me. He wants to relieve that so he can feel that he can read and get back to work as he's here. And he's taking ibuprofen. He's saying he's taking it twice a day, 4 times a day, which sounds very textbook, doesn't it? And I think it's a bit like smoking, to people taking non-steroid or anti-inflammatories. always the figure they give you may not be the figure they're actually taking. It could be more. And I always have that in mind. You know, people say they're only smoke, I only have a couple a day, but they probably meant 10 a day by a couple. So it's the same sort of principle. Trust the patient, but be wary that maybe there may be more medication going on than what he's saying. But I didn't approach it at that stage. But I'm still trying to rule out primary or secondary. So what do? Well, the NICE guidelines say, as primary practitioners, we can do these things, and we should do these things. And this is for doctors, but it also applies to osteopaths. We're in wild practice where anyone can come in. We should be doing the same thing as primary care. Measure the blood pressure. Well, that's really what I did after the first one as well. Palpate the temporal arteries. It's something we can do very easy, and we're probably better at it than a lot of GPs at that. We can palpate to see if there's any pain and tension over that area there. Do a neurological examination. Know your neurological examination. Know your basic cranial nerve examinations. You'll not expect to examine them like a neurologist would do, but your primary care neurology exams, your upper and lower limb neuros, your cranial nerves as well. And fundoscopy as well. Use that if you feel practiced in that.
That's a bit of slide, and you know it's slightly controversial on the syllabus of cranial clinical neurology, etc. It's not necessarily taught undergraduate.
Okay, so they don't teach it undergraduate anymore.
No, it's taken up because the fact that they don't do it enough. So they're not competent enough, they don't see enough normals, so therefore they won't be picking up any abnormals.
Yes.
So it's now something the undergraduates are not even asked to get an ophthalmoscope now.
Okay. Really interesting, yeah. Obviously changed since my day where you were trained in endoscopy as part of your career.
Yeah, I was trained in it, but it's not.
Not that. Yeah. So, obviously, if you haven't got the skill, it's back to the GEOS guidelines. You haven't got the skill, you don't use it. You refer on if you feel it is appropriate and necessary to the GP to do the fundoscopy, or the neurologist if you have contact with them. And of course, this is the NICE guidelines as well. Something that we're very good at. Examine the neck for stiffness, range of movement, tenderness. I mean, that's our bread and butter. We can do that, and that's what NICE wants every primary care practitioner to do, to rule out the secondary signs. Okay? But what we can also do, it's a bit of a blurred picture, but it's really to give you an idea of the scope that in osteopathy we can go beyond that. If you want to really rule out secondary headaches, you can palpate from the tip of the nose right the way around to the occiput. You can look for any headache which is coming from the cervical region, cervicogenic. You can look for greater occipital nerve headaches due to palpation. You can look for anything to do with the ear due to palpation. You can obviously the temporal artery at the top, sinus headaches, your frontal and maxillary sinuses particularly, anything to do with the nasal. A really interesting point, one that I use quite a lot in clinic, is above the eyebrow. It's the supraorbital nerve and supratrochlear nerve. It creates a lot of neuralgias. We all frown, we all do things, and tension, stress, reading, poor eyesight may cause pressure on that and can mimic a migraine type headache as well. So you can feel those. So you can do a lot of palpation to rule out a lot of secondary headaches as well. So if you wanted to, it doesn't take long. So it's all with the neck examination, you could include that. That's not in the NICE guidelines. It's not that we would expect primary care practitioners to do, but you've got that facility to really rule out if you're suspecting anything. So what was this guy's findings when we did our secondary examination for secondary headaches? His blood pressure was still quite high. He had palpatory tenderness in the suboccipitals. He had no temporal artery tenderness, so we were happy with that. His neurological examination was normal again. Cervical normals were normal range, and stretching forward really relieved his pain. That was what he said. He said, "Oh, I'm going to put my head forward. It really helps as well." So we're happy again that we want to sort of have a look and see is there any secondary headaches. And this is why I said know your classifications, know your structure and classifications. I'm not going to go through all these. As I say, there's so many subsections of these as well. But the main ones is, sort of know the categories. If you know the categories of what's happening with headaches, and again, available on the websites and very, very easy to access through Google, is all what it is. Make sure that you know the main categories of what will be causing a secondary thing. And ones that we obviously deal with quite a lot of is number 11, headaches of facial pain attributed to the cranium, neck, eyes, ears, nose, sinuses, teeth. Well, we showed you a palpation where we can really sort of narrow that differential diagnosis down on there as well. And then obviously cranial neuropathies and other facial pains, trigeminal neuralgia is in part 3. Number 5, headaches according to obviously trauma or injury to the neck is the one that we see a lot of. Secondary headaches relating to that as well. And number 8, substance or its withdrawal. That's where your medication overuse headache is. It's a secondary headache related from, but could be caused with primary concern. And that's the one I wanted just to have a little look at, because it's the one that there is a lot of debate within the medical profession at the moment. Is it overused, this term, medical overuse? It's a very buzzword. Oh, they've got a rebound headache because of that. And if you reduce their medications, the neurologist I work with in Cardiff, who refers patients to me and I refer to him, he always, you know, this is his big thing. He thinks, oh, lovely, if we can reduce their meds, we're going to get their headaches down, is one of his things. And he gets them onto more, away from their normal headache medication. But the key thing is suspect medication overuse. As I said, with my patient, he was, 2 ibuprofen 4 times a day. You wouldn't think that was overuse, but is he really telling the truth? Is one. Make sure that you can be aware of that as well. Look out for, sort of the symptoms can be mimic migraine and tension types headaches as well, so they can. And the key thing is withdraw it. If you withdraw the medication and the headaches get better, then that's brilliant. If they get worse after you withdraw the medication, well, it's not a medication overuse headaches. It's not rocket science on that one. Just ask them to have it. But obviously, a lot of patients are reticent to reduce meds as well. So a lot of that is within conjunction with their doctors or their other primary health care practitioners. But it is really important. Debates about giving medical advice, isn't there? With this GEOS talk this morning. In case of are we sufficiently trained in pharmacological advice to be able to say we want you to reduce your medication? I don't know how everyone feels about that. Would you say to a patient, cut down? Yeah.
The evidence seems to show that if they're taking headache medication on more than 2 headache days a week, they're perfectly likely to be suffering from medication overuse headache. So I've had this out with a neurologist as well, and he says it's not really medication overuse headache if it's working. The point is, if they're still getting the headache or the headache's getting worse, then it isn't working, and they're taking it too often, so they're likely to be getting rebound headaches. But he then works with them. Even if it's working, he works on to reduce that. They generally recommend cold turkey, but it's, as you say, it's very difficult just to take somebody's crutches away, because basically they need to go cold turkey, but they need some hand holding. And maybe they need a prevention medication for a while, to cover them.
How long do we do that? Wait for the results. So obviously if it's withdrawal headache, they're going to get worse, obviously, before we know whether it's worked. So they're going to panic and go, okay, that didn't work, and then just start taking.
They need to be told that it will take. I think Dr. Dowson said to me a couple of weeks. It depends on whether they've got caffeine in the drug. Some of these delicious over-the-counter cocktails have caffeine in them, and then I'd have to double check this. But off the top of my head, it takes the next 3 months. I think it's a month with no caffeine, and then it takes much longer.
Headache diaries are the key thing for that. If you are taking anyone off, get them to write a headache diary as well. And my last slide today will be about headache diaries. So it is a key thing. If you are unsure of the diagnosis, if you think medication off you, which is an unsure diagnosis because you're not sure if it is, headache diaries are the key way to go.
You often get abdominal upsets if they're on too much abdominal upsets.
Oh yes, absolutely, you can have other gastric signs or anything like that.
But that's often an indicator.
Yeah, that can be an indicator that they're having too much, absolutely, if they're absolutely.
I don't think it's very difficult to get the GP or the neurologist on board, because it's so well known across the medication overuse is the #1 cause of primary headaches, I think. So everybody knows it. And so if I'm not comfortable with telling patients to come off their pharmaceuticals because pharmaceuticals then it's not my bag. But if I write a letter to the GP or to the neurologist and they do it under their guidance, most of them, and the patient wants to do it and you're on board with doing it, then I find that a little bit more of a comfortable way to do it.
Absolutely. I think that's, you've got to be comfortable.
Does it have to be prescribed medication, or could it be over the counter?
No, it could be totally over-the-counter medication. No, a lot of people to over-medicate themselves far more probably than they do prescribe.
So they're not discussing with the doctor.
It's an interesting point. Yeah, if you feel qualified to do so, as it says here, then you feel qualified to talk to them about their over-the-counter, maybe not buy that, those packs of ibuprofen or paracetamol.
It may sound like a silly question, but how do we gauge, or how does the patient gauge whether that is working? So if you say they're taking ibuprofen, paracetamol off the shelf, they might think, well, I'm only taking one in 4 hours, so then I'll up it because that's not working. So how long do they give it?
Well, it's a very complex thing. I mean, it's a bit like how long is a piece of string, because it is individual for the individual patients as well. I mean, you've got to look at an individual management, and that's where my qualifications lack, where I would want to be on board with someone with pharmaceutical knowledge and somebody who's got more. So that's where the GP's expertise comes in far more, I think, in terms of being able to manage drug medication, because their qualifications and study in that. Or a good pharmacist. A good pharmacist.
Years ago, when I shadowed a neurologist, he kept talking about paracetamol-induced headaches. Obviously, you're talking about general medication-induced headaches. Is paracetamol more likely to cause these?
No, a lot of people. It's just more commonly used. I think that's what I mean. A lot more people use paracetamol because they can readily get hold of it. So rather than ibuprofen, paracetamol is probably the most common medical overuse because you can self-prescribe on top of your other meds.
But it does basically, as a definition, it covers all headache medications. Weirdly, it doesn't seem to happen with things like, for example, if somebody's taking these things for back pain, they don't give you a headache. I mean, they all have headache as a side effect, actually, headache medication. Interesting.
Absolutely.
But even the prescribed, it doesn't matter if it's sumatriptan, if you're taking it more than twice a week, or more than 2 days a week, that's different. The doctors will want to put you on a prevention. We'll talk about that later. Yeah.
And I think that's an important point. What Lena has just risen. It goes back to our first slide of the hammering in the head thing. Headache is a symptom of many different things. So if someone comes in with back pain and a headache, it may be their medication is causing them the headache as well. So you've got to look what's causing the headache. Anyway, moving on swiftly. With this patient, I was now in a conundrum that is probably a primary headache as well. Looking at the difference between, or the secondary headache, cervicogenic in origin as well, or maybe concurrently. Maybe all three were going on with this patient, but I couldn't rule out at the time. But I was happy enough that he was now getting towards the primary treatment that I had. And this is the chart I use, which I find really great, because it helps me differentiate it. Just to briefly, things you'll have access to this and you can look at the things online, but basically what you can see, we can start really looking at this patient in terms of what it's likely to be. Does anyone from looking at that chart think what the patient's diagnosis I went with in the end? From looking at that, we just take a
Cervicogenic?
Yeah.
Cervicogenic. Any hands up for cervicogenic? We've got 3, 4 cervicogenic. Anyone else? Any for migraine? Who's migraine? Who's on the migraine? I think I went for migraine. Got 1 migraine, 2 migraine.
You had the nausea, the light sensitivity.
He had all that, yeah.
Yeah,
he did have that, yeah.
And it was
relieved when he flexed
Relieved when he flexed his down, yeah.
But he was worse lying down. That was what troubled me.
Absolutely.
That's the blood pressure.
Yeah, maybe, yes.
That could be compression.
And what about tension type headache? Any tension? We've got 1, 2, 3. I went for tension type headache. The reason being, again, it's not an exact diagnosis. He got better with treatment, but I think what I was happier with this. I remember more than one headache can happen at one time. He could have had elements of atypical migraine. He could have had elements of cervicogenic headache. And I think there was and that's the grey area of headache. You can't do it there. But diffuse, it was diffuse pain. It was occipital temporal. It was diffuse to both sides, bilateral. That was why I went for that one, the bilateral pain, which is a tension type headache.
But Mark, 25% of people on migraineurs don't have unilateral pain.
I know.
Anyway, it was your patient.
Yes,
so.
yeah.
I'm not arguing, but
I know, and this is where the debate is in headaches, and this is one of the keys, is to have something to do that. He had more mild, moderate pain when I saw him the second time. He had the frequency was longer. He had this headache constantly for a month. That's what I'm seeing. So the 1 to 30 days was another thing as well. He had full range of neck movement, but which is often the case with tension type headache. Neck movement is not typical causing problems. So he could range the neck, but it was relieved by stretching down, as we said.
Thoracic.
It could be his thoracics were tight, which was from his first history that we knew that he had thoracic pain and cervical pain as well. He had light sensitivity more than he had the nausea. The nausea lasted 3 days and then went away. A brain stem symptoms and things like that. He had kept with the photophobia. So I went for that. But you can see how complex it could have been all three. And that's why I say which one we all have elements of each. And that's the thing, bear in mind more than one gone. But we treated him safely because we thought it was a primary headache. And he got better. And he was much better. He got back to writing scripts. And hopefully happy ever
So
after.
what did you actually do?
What did I do?
You said you treated him.
Treated him, yeah. My treatment, my treatment has worked on a lot of what I can treat osteopathically from my point of view, which is what I can do to help his function and structure. So I treated a lot of his neck, suboccipitals. I looked at a lot of the neurological aspects of the trigeminal nerve and the greater occipital nerve and what I could do to help with those aspects of his pain. I looked at worked for the aspects around his facial tension points as well. I worked as a way into the trigeminal on the supratrochlear nerve aspect area and on the corrugator superciliary muscle as well, which is quite a nice effective treatment to get into the trigeminal nerve. My treatment was sort of very manual therapy treatment as well, and he got better. He felt relaxed. He felt assured and things like that. So there was no specific treatment that I would have done, differently, but very general. I didn't do any HVTs. If anyone was thinking that, I didn't feel that was appropriate to do anything, strong manipulations to the neck. And he had a good range of neck movement, so I didn't feel like neck mobility was something I needed to worry about. So just to finish off with brief, and then I can get on. Sorry, I'm running over a little bit. Is that the headache diary? If you cannot diagnose or you're not confident with your main diagnosis, ask the person to record the headache diary. There are many online templates of headache diaries these days. Not which one which you find simple enough for your patients. There's complex ones. Some work for some patients and others not that. But I think the key thing is to make sure that they are recording their symptoms. Remember, more than one type of headache exists, and that they include any triggers such as postural changes, which could be suggestive of raising the ICP at sort of the red flag level. Associate symptoms and use of allergies and caffeinated drinks. We talked about caffeine. It's important to have those, particularly if you're looking at medical overuse headache as well. And refer for a specialist assessment if you're not sure. If in doubt, check it out. It's the simplest form today. Don't feel that you should and ought to treat it. If you don't know what you're treating, don't treat is obviously a key thing with headaches as well. Because it could be something more serious. What I use as a quick algorithm, you can download it off the net. This is what I've got in my clinic drawer laminated. I'm very low tech, so I keep everything laminated in the drawer as a way to think. This is my quick reference algorithm. It's from the Canadian Family Practice website. I've given the www.cfp there. You can find that. And it's their quick reference for primary care algorithm. It's what I find is very useful. Why I like it. Yeah, sorry. Yeah. Everyone got the web reference? Again, it'll be on the slides. Why I like it is these things. It gives you the red flags. It tells you about the red flags nicely. Yes, no answers. You can have a little look. You have it there in front of you. You've forgotten what are the red flags. Well, what does Snoop mean? All those things. It gives you that idea of things and the possible indicators of secondary headaches as well, which I quite like as well. So you're looking for these abnormal neck examination findings. And remember, it's written to family practitioners in Canada. It's not relevant, the whole thing's not relevant, but the key thing is looking for this basic structure. Red flags, possible indicators of secondary headaches. These are the diagnosis that you want. And then headaches, greater than 2 of these, nausea, light sensitivity, your migraine type symptoms. Yeah, you're saying yes to migraine. If it's bilateral, non-pulsating, mild to moderate, not worse by activity, probably yes to tension type headache. It gives you a structure. It also shows you the bit about medication overuse, what they might be taking, and what's considered the safe limit as well, which I quite like. It gives me an idea. What is that overuse? Is that underuse on certain medications I can never keep up? But that's why I quite like it as well. It's got that, and it tells you about your uncommon primary ones as well, with syndromes as well. So it tells you what you're looking for with cluster headaches and those, so you can say whether you think it's more likely to be that. And I think it's a quick reference guide in your clinic drawer, which I try to find useful. I still use it, even though there's some knowledge of the thing there. But there's others. It's the only one that I'm just saying what I use. So just in conclusion, going back to probably the words of still, with a find it, fix it, leave it alone. When it relates to headache, finding it is the key. Have that stepped structural diagnosis. Have a look at, know your classifications, know your red flags as well, that's the key. Fix it only if you feel it's safe and appropriate to do so. Don't be afraid to refer. So don't be afraid to leave it alone. So that's the way. Thank you very much for your time.